I'd like to welcome everyone here and that may be seeing this recording in the future to the council's presentation on the No Surprise Act using good faith estimates to market your practice by our good friend, Dr. John Davila. And Dr. Davila is a chiropractor and graduated from 1994 from Palmer College. And after that, he ran 3 very successful practices in Myrtle Beach, South Carolina. And then in 2000, started his company, Custom Chiro Solutions, which has been offering chiropractors information on federal and state insurance compliance ever since then. So I'm going to turn it over to Dr. Davila.
Thank you, sir. I appreciate it. It's good to see everyone again. I hope the last time we all talked, which was at the council's convention in New York, was helped people get some stuff together and really helped them improve what they were doing. So I know we had talked earlier about what we're going to do in the future, which is now this. So this is what we're going to talk about today. We're talking about No Surprises Act, but it's going to be a little different. There's some data that goes into this, and there's also talks about, we're talking about that how can I put this, the data that's there and how it all works and how we get to that point, what you got to do, and I'll even give you some other stuff as well. Just a little housekeeping first. This should go relatively fast. I don't think we should be here more than 35 minutes, somewhere there, maybe a few minutes more. If you have questions, everyone, by the way, everyone's muted. Questions, go ahead and put them in the question and answer, put them in there. I have the chat box open as well. So I have all that there. And questions and chat box open. So if you put stuff in there, I'll go ahead and break every few minutes. If I see something that's coming up, I'll answer that as well. So let's go get started. The first thing I want to put out there to everyone is the reason why I'm here. Okay, so the reason why I'm here is because I'm committed to what my dream is. And I say this kind of sounds kind of weird, but it's totally true. My dream is so that my clients, the people who listen to what I'm talking about, the people that come to events such as what we did with the council earlier, so they practice from a position of power and not from fear. And I hate when people start looking at stuff, oh, it's so scary, this is scary. This stuff isn't scary. If you know exactly what the rules are, the game is easily played. So if you look at it from that perspective of, the game of what we have to do, we win when we play games, right? So if we win when we play games, the only thing that we've got to worry about is not the game itself, but designing the game so we win. So everything that we do as a company is all based upon reverse engineering. Everything we do, we manage from macros of clients, and we customize their EHR system to figuring out what their fee schedule should be, figuring out what their discount should be, all those different things. We'll talk a little bit of that later. But all that stuff is always reverse engineered from the place of which we want to end up. And it's the same thing here with No Surprises Act. The good news is 99.99% of the No Surprises Act has nothing to do with us. There's only one small piece, which is the good faith estimate. So we'll talk about all that stuff. But I just want you to realize that as we go through this, yes, it's compliance. Yes, it's all these different things get involved in what we want to do, which is basically put our hands on people and adjust them. But if we know exactly what components that we have to deal with and we use them to our advantage, then we could actually play this game from a winning perspective, which is really what we want to be able to do. So as we go through this, really the idea here is to figure out, what does this do to us? Where does it all sit? The funny part is that we have people that walk in like this. Yes, I got insurance, right? And then we have people go, oh, well, I owe how much? And I love this slide because it takes people from the perspective of, oh, I have this card, to I may be uninsured or I may be underinsured, right? And that's an important component to look at, because it's going to be people that are both don't have insurance and people who are underinsured are going to be the main issues here. And then all the people that do have insurance, but have some coverage. So as we look at this No Surprises Act and prohibition on billing, all this stuff here, this is really, really fast. This is nothing to do with it. So all the stuff about balance billing that they talk about you can't do has nothing to do with us, right? So all these different things. No Surprises Act requires health plans and issuers to apply in-network cost sharing terms. So all this different stuff on prohibitions of out-of-network providers. And all these different things have nothing to do with us because it's only for these three situations, right? Emergency covered services from an out-of-network provider or out-of-network emergency facility, not us in the chiropractic office. A person gets covered non-emergency, gets covered non-emergency services from an out-of-network provider delivered as part of a visit to an in-network facility. Definitely not us as well. The third one is, covered air ambulance services. And even with these three things, there's been a bunch of lawsuits to go ahead and chip away at this over the last year. So here we are looking at the issues of, people talking about, oh, we can't balance bill. That's not true. So when we talk about balance billing, let's understand what that means. Balance billing means I charge $100 for a service, and the insurance company, as an out-of-network provider, only allows 50, right? And of the $50, they pay 80%, right? So if it's 80% of 50, that means they pay 40. The copay is $10 to equal the 50, so 40 plus 10 equals 50. But the patient, right, should be or must be balance billed for the difference. So the patient's true out-of-pocket cost is $60 because they owe the $50 for the write-off that you don't have to write off because you're out of network. They owe the $10 for the copay, and then the insurance will go ahead and reimburse the patient 40. So really, you have $60 out-of-pocket expense. That's called balance billing. You should be doing that. If you charge X, you should be collecting the difference. That, even though it says there's a prohibition on it, has nothing to do with us. It's only in those three situations. So I know I've seen a couple things. Well, we have to worry about, about balance billing, everything else. Not true. Okay. So all of these things, limited situation, no surprise act allows some out-of-network providers and facilities to seek written consent. Once again, has nothing to do with us. And then we get into scope of providers that must comply. Physicians and other healthcare providers, right, under applicable, that is true, but it's covered emergency services when providing care as an out-of-network provider at an emergency facility. Once again, nothing to do with us. And then we get into scope of facilities must comply with No Surprises Act, prohibition on balance billing. Once again, emergency departments, hospitals, independent freestanding emergency departments, right? All of these things have nothing to do with how we operate, okay, in the typical chiropractic office setting. So we get through all these different things and none of this stuff, right? Out-of-network providers, non-emergency services, equipment, imaging, telemed, lab, preoperative services, post-operative services, nothing to do with any of that. So really the first few seconds on this is what does this have to do with us then? If all this stuff has nothing to do with us, then where does this whole No Surprises Act come in? And the truth is it comes in here when we get into, the good faith estimate, okay? So we're gonna go through, who's included, what's the threshold, what's to include the GFE, the signs, website pages, and also I'm gonna add into that FAQs. There's a bunch of FAQs, a little fine nuanced things that go into that as well, and what's coming up for 2023. So this is the data that we should have going forward. So once again, we're gonna play this game, then I wanna know right here exactly what I'm supposed to be doing for 2023. Because if I know what I'm doing for 2023, then I can play this game. Because the truth is, if I have it all played out in advance, I know exactly what I need to do. So right here, that's the big one. So if I know exactly what I'm doing, I can play this game in advance, no problem at all. All right. So here we go. So who's included? So the first thing is obviously, if you are, let me just go ahead and do some housekeeping there. There we go, no problem. If you were generally considered uninsured or self-pay individual, if you do not have health insurance or do not plan to use your insurance. So it's both they don't have insurance, right? Or they're underinsured, or they don't want to use, they're not going to use their insurance item of service. If you're uninsured or self-pay individual, a provider or facility must give you a good faith estimate detailing what you may be charged before you receive the item of service. So all they're saying is they just want really transparency before the patient actually gets the service. That's all it is. Okay. And to be fair, I'd say 99% of your patients, understand what's going on. And I would say 99% of the time, if you say you're going to charge X, the patient gets charged X, and that's just how it is. But there's some issues, and this doesn't, remember, this covers all of healthcare. it isn't necessarily directed at anything that we're doing as a group, right? I don't think people sat down and wrote this good faith estimate thing and said, oh, well, you know, chiropractors are bad because they do X, Y, Z. I don't think that's the case at all. That's not what the point of this was. The point of this really was to get a lot of other situations in check. So we just happen to be caught in the crossfire here, right? So now who's excluded? Okay. Healthcare providers aren't required to provide a GFE to those who are covered by Medicare, Medicaid, Indian Health Services, Veterans Affairs, or VA, or TRICARE. So these people do not get a GFE. Okay. The reason being is because they already have a couple things in their favor. If you were par, they have the fee schedule, Part B fee schedule. If you are non-par, they have the limiting charge. So they already have for their covered services all the maximum service, all the maximum things that you can go ahead and charge them. Okay, so that you don't have to give them a GFE because they already have their max fee schedule already lined out. So I hope that makes sense. So it's really weird because I know a lot of people go, oh, Medicare's involved, CMS is involved, and all of a sudden I don't have to give this to a Medicare patient. Exactly, which is crazy. Okay, but remember the reason being is because that fee schedule for Medicare is basically set and you can't charge the patient more than that. Okay, and that's how it works. All right, so now we have to figure out, okay, when do we send this? And this is kind of interesting, right? So if the appointment, right, a service is scheduled to be 3 to 9 business days in advance, right? In number 1 here, within one day of scheduling. So it goes right to this one. If the appointment is scheduled at least 10 days in advance, right, within 3 business days of scheduling. Okay. If the GFE is requested for a non-scheduled appointment service, okay, you got to send it within 3 business days of the request. So as we have this, that's the way it works, right? So it's no big deal. So, okay, what about, and here's a quick, great question mark. What about non-covered Medicare fees? Okay, so let's understand in this situation here, non-covered meaning wellness care, because remember we want to make sure we use the right terms. We have 3 different types of Medicare services. We have covered, non-covered, and excluded. Okay, covered is 98940 AT, non-covered is 98940 GA, and then excluded services. Okay, so for excluded services, like it says, you don't have to do any of that stuff because it's an excluded service. So Medicare patients don't have any of these issues. So you don't have to worry about any of those things. You're talking about exams, therapies, and x-rays. There's nothing to give them. They've already been excluded outside of that. And that's one of the positives, and because they only pay for the adjustment, we're there. So exams, therapies, x-rays, we're outside of that. There's nothing to give them because they're excluded. We have to give them one. Okay. So great question on that one. Okay. So no problem at all. So now when we have this, so if they want these are the 2 different situations that we got to worry about here. All right. That's number 1. This is number 2, and that's number 3. So just get that down so we have that all lined up. The best idea for this is to have the staff understand that if they schedule this, that we send them out something very general. Here you go. This is our fee schedule. Here's GFE. The reality is in this situation, it's really hard to go ahead and figure, okay, well, I'm going to give you 75 different visits or 20 visits or 10 visits. I've never even seen the patient. Once again, on the flip side of being caught in a crosshair, that's one of the not fun parts to this. So we're going to be looking at either doing a couple different things. One is a sample type of care plan that we're going to do, or we're going to go ahead and just create a short version of a fee schedule and say, this is what we're going to send them. Okay. And that probably will be the easiest way to handle it. Here's my good faith estimate of day 1. And it's going to be 1 exam, 1 this and 1 this. And then it's based upon, what codes, and you have a basic fee schedule set up that way. So it's a pain in the butt, but here you go. These are the dates at which we send them, right? So date of scheduling versus, okay, or request versus date of appointment. Remember, the date of scheduling, here's one of these finer points here. The date of scheduling is the day that the future item or service gets booked in the appointment calendar. The date of request is the date that the patient asks a question, or basically any question related to payment. GFE timelines apply to either date of scheduling or date of request, not the scheduled date of service. So if they call on the 1st, and they want an appointment on the 10th, right? it's all based on the 1st. It's not based on the 10th. Okay. So the clock starts at the point of scheduling and deadlines work forward from there. This may mean the GFE sent weeks or months before surgery, for example. And as you start to read this commentary that I've taken from CMS's website and everything else, you start to see a lot of this stuff has mass amounts to do with things that are fixed going into the future, like a surgery months before. Okay. And then we're just kind of stuck in this, well, I don't know what I'm going to give the patient. That's the reason why this is really, really a fluid thing for us to deal with, right? So next thing, what's the threshold? Okay. If you get a bill that's at least $400, the threshold really means, where can the patient complain and how that all works. If you get a bill that is at least $400 more for any provider facility than the total expected charges for that provider facility on the good faith estimate, there's a new patient provider dispute resolution, or PPDR, process available to the patient. Okay. On the PPDR process, you may request a payment review and decisions from an independent company certified by HHS. These companies are referred to as selected dispute resolution entities. The SDR entity will decide what amount you must pay. If your bill is at least $400 more than any provider or facility, then your good faith estimate from that provider facility. So here you go. So the whole idea about, well, can the patient go somewhere and have them review my bill? The answer to that question is yes, they can, but it's going to cost them money to do that. Okay, so it's going to cost them money to do that. But then again, we have to ask ourselves, how many times if we give the patient, this is what we're going to do. This is, even from what we're looking at. So they call, say, I want day one. Well, here's my exam. My exam is this, and my x-rays are this. I find it hard to believe that we're going to be more than $400 off in that process on a typical basis. And once again, if I use the 80-20 rule, that's probably where I'm looking at this. 80% of the time I do the same. I do something that's kind of normal. 20% of the time there are outliers. 80% of the time I'm probably going to be well within, if there's any difference in the fee, well within that $400 number, without a doubt. Okay. So what's included in the GFE in this example, even though the total of all bill charges for the provider, $2,400, is greater than the total expected charges of $2,125. The difference billed between the two charges, the expected charges are less than $400. Therefore, it's no big deal. What that means is the patient, right, expected this, but this is what you actually billed the patient, right? So that's a difference in fee. Now, here's the thing. This is for, if you look real closely, before people go, oh, wait a second, what if something changes to the patient? If something changes to the patient, you get the opportunity to tell them. What they're talking about here is a difference between the price of each item, okay? Not the number of items, okay? So if the patient you thought only needed 10 visits, but they needed 20 visits, that's not what we're talking about here. They're talking about the actual bill charge for each individual service, okay? So the difference is the charges are different between $400. In this situation, it's less than $400 here, between here and here, right? And because it's less than $400 between here and here, there's nothing for the patient to complain about. Okay, so just understand that number is $400, right? So now that we know what it is, okay, and we know what the numbers are, like I said, this is really, really, really simple stuff. So the important component to this really is what are the more nuanced FAQs that go with this. I think they're more important than looking at what is the $400 limit. But let's go through this. So if you're looking at multiple doctors in office, co-providers, co-facility collaborations, right? A single GFE is totally fine. So if you have more than one doctor in the office, totally fine to have a single GFE. Okay. For mix of in-house providers, consultations, follow-up care, all different stuff. You have one GFE for the entire thing. That's totally fine. Okay. So you don't need to have separate ones for each individual doctor in the office for that idea of what the patient's going to get as a whole. Okay. So very, very simple there. The next one, okay, what if there's no expected charge? And this is crazy, right? So the GFE will still be required. There are no minimum qualifying payment amounts. Expected charges GFE include estimates of no financial responsibility, such as when the provider anticipates a zero price. So if the patient's just coming in to go ahead and just wants to go ahead and talk with a doctor, and they want a GFE for that. There's something there's zero, like you had X-rays taken, and now because you got paid for the X-rays, now they want to come in and they want to ask you, is there a GFE for the report of findings? There's $0 price, because the report of findings charge is included in the X-rays themselves and in the E&M code according to the 2021 rules changed. So now there's no fee. And because there's no fee, patient comes in, they want a GFE for that. No problem, GFE is zero. So you can actually tell them the GFE for a service like that is zero, and there's no financial responsibility at all. Okay. So what if a patient loses insurance? Let's see, John has a question, Otto has a question. All GFEs on a letterhead and written can be texted or emailed. I'll get to that in a second. That's a great question. If the patient loses insurance coverage after scheduling the service, okay, at the time of scheduling, this one's actually pretty interesting. Always ask whether the individual is uninsured. Okay, if they are insured during scheduling, but they lose their coverage within 3 business days before the appointment, this is the number, 3 business days. There's no requirement in the No Surprises Act to provide a GFE or reschedule the appointment. CMS does suggest that providers or facilities ask patients to report when their insurance information changes. So, so that new GFE can be issued if they become eligible before the appointment again. So just, so when we look at this, just understand, if the patient's insurance changes and they didn't tell you, you're basically off the hook. There's nothing more to give them, right? So we have one more question here. Brian says, new patients, we would have to send them a written estimate of cost. That is correct. Verbal over the phone is not good enough. That is correct. The GFE sent to those requested by name implying, ask how much the first visit. That's correct. When new patient, that is correct. Ask how much the adjustment is, and we do care plans, but we don't know what the patient is. Okay, so basically you're telling them that's correct, Brian. So you're going to basically manage what the cost of the 9940 is, and then from there, that's your fee schedule. And then you're going to go ahead and tell them what it is that you're doing later on as far as an estimate. Because everyone, believe it or not, if you're doing a care plan, you're giving an estimate anyway, right? So you're doing that in I'm sorry, Tim, the questions. The question was, let me just read that out loud. So for new patients, do we have to send them a written estimate of cost? The answer is yes. You send them something written. Verbal on the phone is not good enough. That is correct. GFE only sent to those requested by name, implying how much is in the first place and how much is the first visit. Yes, if they ask, you send it. Okay. When new patient asks how much is an adjustment, we do care plans, but we don't know how much the patient will need. Correct. You only, and it goes, do you send them the fee for 9940? Yes, you send them a fee for 9940. That's what it is. So that's what you would send them, right? And then from there, you're going to give them a full estimate before they purchase anyway. That's your report of findings. So that's how that would work. Hopefully that answered that question for you. So definitely, that's how we definitely want to manage that one. So those are great questions, Brian. That's exactly what it is that we want to manage there. Okay. So next one here. Next one. What if you don't know whether the patient is self-pay or uninsured? Self-pay, uninsured, underinsured. The providers are responsible for knowing the patient's insurance status. Consider implementing changes to intake forms, scheduling scripts, right? So the patient's so you're responsible to find out. So you got to ask patient, are you insured? Yes or no, right? You just got to figure that out, and then go ahead and tell them, here's your GFE basically, and you can ask directly if they intend to self-pay for services, that whole thing, right? Do you have Medicare, all different stuff. Doug has a question: is listing fees on the entrance form for all your services good enough to GFE? That answer, so is it good enough for all services to list it entrance form? The answer is no. You have to actually, if the patient wants it, you have to share it based upon that information, based upon the which I showed earlier. So let me go ahead and show you one more time right here. So if they make the appointment, this is what they need. Now I'm going to get to Doug. There's a second part of Doug's question, which is going to be what's in the office, which some people will get a kick out of. But as far as having that stuff, if they want it, you give it to them in advance. Next one. What if the good faith estimate scope or provider changes? Okay. And this goes into the question of what are we doing as far as when we change the care plan for the patient. Provider or care plan changes, provider must send a new GFE within 1 business day before the scheduled item or service is rendered. The new provider must uphold the original GFE if the provider changes less than 1 business day before the scheduled item or service. So really what we're talking about here is if they're talking about here changes to procedures don't really apply to what we're talking about here, because now the patient comes in, we don't know what we don't know what we're going to do for them going forward. They come in, we manage them. And you got to understand, this is a situation where we're trying to fit a square peg into a round hole. This really doesn't actually fit into what we do as far as, how we're managing patients. So it's impossible for us to tell the patient they need X number of visits before we talk to them. It's a lot easier if someone schedules a surgery. So if they schedule a surgery 3 months in advance, this is exactly what it is. Okay. So the good faith estimate here kind of is a little bit different in scope compared to the way we're managing. Okay. So the next one here, retention requirements. How long do we have to keep it for? Okay. So the good faith estimate becomes part of the patient's record. So it stays in there. It says here for at least 6 years. And that's how that works as far as whatever is with your medical record. Okay. So the question is, do we send a GFE only if they request? Another good question from Doug. That answer I've seen come back both ways. That is no, you don't. And then I've had people say yes. I've actually read different legal opinions that say it goes both ways. If the patient calls, you could basically ask them, would you like a GFE, and send it. That's how it works. So I have no problem with that. That's an answer I can't give you because I've seen multiple different ways and haven't really gotten a square answer myself on that one at all. So the next one, Steve asked, does impact new patient offer $100, $150 versus when regular fees are $300? The answer is no, it doesn't impact that at all. And the reason why it doesn't impact that is because when you told the patient it was $150 to come in, that there you go, you told them it's $150 to come in. And it has nothing to do with what it would have been if you're getting 50% off your visits or anything like that as far as discounts go. Even then, it's under $400 for that, and that would be totally fine. So the patient really couldn't complain about it because it's less than $400 in difference. So just so you know, so if the patient, new patient offer, that has nothing to do with it, because you're still telling them it's normally $300, but today's $150, and here's the fee. I think the problem would really turn around if you said it was, and this is really how it happens from a board complaint standpoint. Is it it's 300, but I'm going to discount to 150, and then you bill 300 to the insurance company, and that'll get you a board complaint. So I think that one is kind of easily understood on that one as well. Okay, so next one, is there a specific form for GFE? Susan, give me 2 seconds. We'll get right there. I'll actually show you that as well. All right, so the next one, as we look at here, right? So signs and website pages. So now we get into the question about, can I have it? Can I have the fees on my front desk and all that different stuff? The answer is like HIPAA privacy stuff. Those policies are some of them on your website. Some people have them in their office, in their office in books, in manuals they have sitting around for privacy, things like that. GFE notice, right? Not the fee schedule, but the surprise act, the notice, the idea that they're allowed to have this information, the GFE notice itself, that should be posted on your website that they're allowed to have a good faith estimate, and that should also be in person, okay, in an office. For my clients, what we do is we have them have their HIPAA stuff in a binder. It sits in the front desk. You put that right in there with the binder at the front desk. Some people have it on the wall in their office. That's totally fine as well if you want to do that as far as something else as well. Depends on however you want to manage that. Okay. So the question Susan had was good faith estimate. This is one of the examples that you could have on your website. This is the example of the good faith estimate warning. Okay. from there. And then the next one is, what are we going to do? So now that we've got all this stuff down, as far as, I have to do it. I have that screenshot, because and by the way, I'll give you an opportunity to go ahead and get notes as well. I have all this stuff down, and I know what I have to do, and I start doing it. Now, where does this help me? Where does this work? Well, there's a component to this where I must actually kind of look out for other people within my circle. And this is called convening provider. Okay. So a convening provider is responsible not only for providing an estimate of their own services, but also all services commonly provided in conjunction with the procedure you're providing. Okay. So that would mean things like, I had surgery, I did knee replacement surgery, and physical therapy is the service that comes commonly in conjunction with that service. Okay. So that's the convening provider. Okay. Regulations define the term convening provider, convening facility to mean the provider facility who receives the initial request for a good faith estimate from an uninsured or self-pay patient, and who is responsible for scheduling the primary item of service. So we have to look at this and say to ourselves, yes, we can manage this convening provider. I have patients coming to see me. Do I worry about if I'm referring out to a PT, referring out to an MD, referring out for MRI, right? So if I look at that, then I can look at convening provider and say, are these things commonly provided in conjunction with what I'm doing from an adjustment standpoint? And I'd say 99% of the time, the answer is probably not commonly provided in conjunction with. Okay. So that doesn't mean that we don't have patients who will ask for it. And it doesn't mean that it's not going to make it simple. So we can actually use this to our advantage, because you're going to have some providers that are going to read this literally and go, well, anything provided in conjunction with what I'm doing is now something I have to go ahead and have a GFT for. That said, what you could do is you could actually use this to your advantage. If you have people that you refer to and they refer to you, one of the things you should do, which is coming up in 2023, is, and they may not know this, you may be, right, someone giving these doctors and their staff some information about things like, hey, did you realize I'm a convening provider facility? You're a convening provider facility. You have to make sure that you have this information to send them. And if you send them this information, right, what do we do? We should have this data. And that goes into, is it on our letterhead? Can it be written? It has to be written. Can it be text or emailed? Yes, the answer is yes, it can be both. So all this stuff can be done on letterhead. In this situation, I waited to answer here, because if you're going to go to another doctor's office and say, listen, there's this whole issue with convening providers, facilities, right? Co-provider, co-facility, the whole thing. I'm here to go ahead and take that worry away from you. Here's our fee schedule. So if you want to refer people to us, you can go ahead and share it with them, no problem at all. So as we manage this from a scenario, a situation where I have a rule, I hate doing this stuff. I know at 8 o'clock at night on a Wednesday, when people would rather be doing something else, they have to sit and listen to this drivel, which I understand. But the truth of this is, we can take this and use this to our advantage, because there'll be people that aren't in on this topic, and because they're in on this topic, it's one of those situations where we can go ahead and use this to our advantage. So in your community, go ahead and be proactive and say, this is what we're going to give our providers, so that they can have all this data and go from there. Now, Joe's got a great question here. Can the GFE be super simple? The answer to that is yes. First, cost for the E&M and x-rays itemized as needed. Absolutely correct. Then office an adjustment code charge for a subsequent follow-up visit. Absolutely yes. So you don't know how much care the patient will need or need based upon how the patient responds. That is exactly the point. Okay, it's totally different from what people are looking at here. For example, doctor probably expects that along with the individual's knee replacement surgery, the patient also be given anesthesia. That's what they're thinking. They're thinking about physical therapy. They're thinking about anesthesia, like all these things going together. Okay. Rather than attempting to detail out how much the cost of care will be over the episode condition being treated, I'd rather just give them the thing. That's exactly correct, especially if you're seeing the patient once they schedule. So they schedule on the first, you send them a GFE for the 3 or 4 services that you might do on day 1 on the 10th. When you get to the 10th, the next time they come in, you give them a GFE when they come in and say, we'll send it to you, we'll email it to you when you get home, or text you tonight. You can come in, and this is, they already have that. And we'll talk about the, everything else later. So you can do all of those different situations, because the basic tenets for this is set up for this ridiculous process right here, which has very little to do with what we do on a regular basis, right? So we don't have things that commonly happen together. So it's basically set up for that. So that's exactly correct. So Joe, you're exactly correct. Make it very, very simple. Be very, very, you can be very, very generic with it. Here's what we do, and go right back to your docs and say, you're good. So Ed asked another great question. So what if the patient calls the morning and wants to be seen in the afternoon? Totally can. And because they can come in that you can text them that day. Like Otto asked, if we text it to them, sure, we can text to them, no problem at all. We text you your GFE tonight, or they come in, we'll have the GFE when you get here, or we'll talk about the fee when you get here. Totally fine. So no problem if they call in and want to be seen that day. No problem at all in that situation. Okay. So one of the questions was, can it be super simple? What does it look like? Right? Something like that. Believe it or not, it's even more simple than you think. It could be just a spreadsheet, really, really easy, and say, here it is. It could be fees on a piece of paper. Here it is. Which there's a little bit more data that goes to that, that kind of thing. One of the options that you have, and if you have Fortis Pay, which I don't operate, but if you have Fortis Pay, we actually do have a calculator that goes in the backside, and it can print out something like this out of Fortis Pay. If you're interested, you can go ahead and get Fortis Pay, and then we have a calculator that goes there. And so when we look at it, so you can be very, very generic like this. This is a care plan that you can send them. It can be one visit. And as Tim asked, does it have to be specific to the patient's needs? The answer to that is no, it doesn't have to be specific to the patient's needs, because I can't tell them what their needs are when they call 10 days in advance. So there's no way to be able to make it out to what we're doing. And then once they come in and you give them an idea, then the next thing they purchase, then they're going to get that idea. Get that care plan next. That's how that would work. Okay. Do I have the patient sign anything, make a copy folder? The answer to sign anything, Linda, is no, there's nothing to sign. But as I said earlier, yes, that becomes part of the patient's file, and you put that in there, and you keep it like as if it was a daily note. And that's where you would keep that stuff there as well. Okay. Let's see. Brian sent me one more thing here. Let's see. When giving a GFE, add a report of findings that includes re-exams, adjustments, like orthotics. Is total cost of goods services enough to give the patient, or does each service need to be separated, itemized? Right. So the answer to that question is, right, can you do it? Can you give the patient a total amount, or can you give them an itemized bill? In this situation, I think an itemized bill would probably be best. That's why I use this as an example here. As far as this is an example, an itemized bill works out really well. That's why we have this here. Plus, it includes a whole bunch of other information as well, provider information, things like that, NPI, stuff like that. A sample for you. It didn't fit on the screen. So if you want it, I will send it to you. I have in fact, I have the actual original of this. If you like a copy of that, I will give you the opportunity to have all this stuff. It comes in one file. I'll send it to you, no problem at all. Just go ahead and email me, and I'll give you the information in a few seconds here. So to be fair, that's really the GFE. It's really no big deal. It's a very simple thing. We give the patient information. We should use this as a marketing situation for us, and go out to the providers that we work with and say, here's all my stuff. Here is my fee schedule for this. You refer to us. We want to make sure that our patients are happy. with the good faith estimate situation that's coming up in January. And we're going to go ahead. We want you to refer to us. Here's stuff. So if they have any questions, here's the fee schedule. That way they know in advance, that kind of stuff as well. So as we know here, we work with all different EHR systems. Here's a bunch of them that we have. I think we're up to 32 of them. Here's very common ones for Cairo. And then, for all the stuff, we want to make sure that you have the data. Don't just ask your buddies, get the data, get it all, get the correct information. And I want you to have the correct information, because the truth is I have no idea whether or not the kid on the right is smart or the kid on the left is smart. Just want to make sure I have the right data. Okay. So we want you to get the right data. So here's how you do it. My information, obviously we customize EHR systems, but if you would like a copy of the download, that gives you a copy of a simple GFE. It also gives you the information as far as how it all should look for your website or a page in your office or something on the wall. Go ahead and email me, info@custom-cairo-solutions, and I will have all that information out for you. No problem at all. You'll have it all in a matter of probably sometime late tomorrow afternoon. I'll get it out to you. And it's really, really not as hard as you think it is. Once you see it, it makes total sense. As far as everything else goes, it's really, really, really simple. We're just going to go ahead and give more data to patients, and that's really just trying to make it. I got with this, trying to make this more transparent as far as pricing goes. Okay. So once again, Brian, you there? You want to get back in? There you go. So
Thank you so much, Dr. John Davila.
Yeah, it's not very crazy, is it?
No, I mean, there was a lot of people that were worried. We really appreciate you making this simple for us. And, continue to put questions in the chat so that if something wasn't answered, we can get back to you. And as this gets replayed, we'll be able to get other questions answered by our expert here. And I want to thank everybody that's a member of the Chiropractic Council that helps us to bring this to the profession in the state and nationwide. I really, it's an awesome presentation. We really appreciate you being here and being a friend of the council.
Awesome. You got it, man. Anything you need, I promise.
Yeah. And I want to let some people know on this call here on the Zoom here of some other opportunities for them. Coming up in January on the 16th, every district will have their Chiro Connect with Dr. Iram Tahir, one of our members from Syracuse. We've got a live seminar in Albany with Dr. Dean DePice on February 25th. Thank you, Dr. Kelly. You're on tonight for setting that up for us. We've got our convention in Niagara Falls, March 18th and 19th. We call that our Lyceum. And our mid-year convention at Turning Stone, April 21st and all the way to the 23rd. So we hope to see everybody there.
Right. One more question. Joe's asking, it's simple enough to simply have a page on your website with its generic GFE for initial subsequent visits, direct the patient to either over the phone or via email text. You could do that. But remember, it's part of the patient's file. So we have to have proof that you gave it to them. So just remember, it would be, you could have that information there. It's totally fine. But once the GFE is something that you give them, and then you put it in the file that you gave it to them. So I don't want to have a situation where I told the patient to go there, they didn't go there, and they complained. So it's just simple to have it that way. So just so you know. So just let you know, Joe. Sorry, Brian.
That's quite all right. That's right. We're here to answer our questions. So that one might not be in the recording. That's the other thing. So, yep. So we know what the council's been up to. Mid-December into January, we're going to have a brand new website where things like this will live, and you'll be able to request or purchase information about this, or how to do an inpatient workshop. Many other things, like we did a work comp informational this summer with Dr. LaMonica. That'll be able to be living there for member benefits and for non-members to purchase, and lots of great things in the works for us. Yep. Right. So unless there's any other questions, we can thank everybody and sign off.
Awesome. Thanks for having me. I hope to see you again soon.
Thank you. Yes,
Anything else, let me
likewise.
know.
Hope to see you soon.
All right, man. Take care. Bye.
Bye-bye.